Thank you, Fred. So I've got about 20 minutes to cover sort of my sense of where we are in terms of cystoscopy, cytology, and some of the other tools that we have, both in biomarkers and enhanced cystoscopy, that I think are really changing the landscape for our benefit and obviously for our patients' benefit. These are my conflicts that I need to tell you about. In terms of nucleics, I've been on sort of an ad hoc advisory board with Fred and a few other people for the last 3 or 4 years as the company's been rolling out its clinical trials, nothing in the last 12 months. And then Jim Cato and I have been trying to figure out a way to get a trial where we can actually develop level 1 evidence to support the use of a biomarker, in this case EpiCheck, and reduce the frequency of surveillance to try to provide that evidence. It's actually a lot harder than I thought it would be. Anyway, what I'm going to cover is white light, the standard cystoscopy that we use, enhanced cystoscopy. I think that one of the sweet spots for a molecular biomarker is in helping resolve the patient with an atypical suspicious cytology. I'll give you some data on that. And then how in various different settings we might incorporate a biomarker into our current diagnostic platform. I suppose the other disclosure is I'm going to talk a lot about fish. And simply because I haven't used EpiCheck to date, so I don't have any personal experience with that, but I've got a lot of experience with fish, and as Fred pointed out, it's a complex test, it's expensive. How much legs it has under him will depend upon the comparative utility to a less expensive voided urine biomarker and the turnaround of that biomarker. So if you look at the EAU guidelines, and Fred's mentioned this already a bit, that our workhorse, the urologist stethoscope, white light cystoscopy, at least under the present circumstances, can't be replaced, nor should it be replaced by a biomarker. And I suppose that should be qualified by really the patient with either suspicion for or evidence or history of a high-grade cancer. There's level 1 evidence supporting PDD, photodynamic diagnosis, and slightly lower level evidence, although I'll show you a negative trial for narrowband imaging, which we've used quite a bit. And then PDD is endorsed by most of the clinical practice guidelines that we have in urology. And of course we have cytology. I'll give you my sort of view of where cytology fits in and what the performance characteristics ought to be for cytology if we're using it correctly. And then obviously I'm going to talk a lot about urine biomarkers. So I think Fred's kind of gone over this, and I think that there's a lot of opportunity for, and I would say that I would be in favor of a molecular biomarker. One of the hats that I've worn is since 2010, I've been deeply embedded in the Cancer Genome Atlas project, so I believe in genomics, and I think that, as Fred pointed out, next-gen sequencing is now somewhat of a commodity, and though it's obviously a complex test, but we've learned a lot about non-muscle invasive bladder cancer in addition to muscle invasive bladder cancer with regards to the molecular landscape and how biomarkers derived from that can help us. So I'm not going to talk about screening or detection in the patient who has hematuria in the initial workup, because that's another complex field. But surveillance, again, resolve suspicious cytology. And what about when a biomarker is positive, but cytology is negative, cysto is negative, what does that mean? If it's a positive cytology for high-grade cancer, it means we got to go find where the cancer is. If it's suspicious, then that implies that that patient has an increased risk of probably 30 to 40% over the next year to two that a tumor is going to show up. I'm not going to talk about upper urinary tract because there's others that are going to address that in the context of this meeting. Several things that we know about white light is that CIS, which of course we worry about, that's a high-grade intraepithelial neoplasm, has a high predictive value for subsequent muscle-invasive bladder cancer, and it's not visible by white light half the time. We miss small papillary tumors, and this is evidenced by just an example in a randomized trial of perioperative, in this case, epirubicin, where you see here in the first 6 months that the recurrence rate or so-called recurrence rate in the first 6 months is identical in the treated and non-treated, and that can only be from missed tumors that subsequently are diagnosed on cystoscopy. And then in male patients, we can't see CIS of the apical prostatic urethra. And particularly in patients who recur after induction BCG and have an unexplained positive cytology, the urethra can be a reservoir for CIS, and the failure to detect that can potentially be lethal to that patient. There's a lot of advances, and this is an area where I have spent a fair amount of time with all the technologies except for confocal microscopy. And so in addition to advances in white light cystoscopy, we now have fluorescence or PDD, photodynamic diagnosis, lots of data showing we can increase the detection of CIS and papillary tumors, and I'll show you in a second that it's associated with a significant, clinically significant reduction in recurrence and progression. Narrowband imaging is a bit easier from a technical standpoint. It's just a switch that you flip on, in this case, an Olympus flexible cystoscope, or one that we use in the operating room. It has, concerns are the specificity, a lot of false positive, as then I'll show you there's been a negative clinical trial. We spent a lot of time with optical coherence tomography, which uses the near red, infrared span of white light, and our data show that we can reliably identify when patients have a T1 or T2 tumor, and that, of course, can drive intraoperative decision-making about how much depth do you resect and give you a lot of confidence on the flip side that you're dealing with a non-invasive cancer. The confocal microscopy is like having a microscope in the operating room, and Joe Liao at Stanford has probably done the most work in that. I'm not going to read this, but suffice it to say that the advances in white light cystoscopy and the technology that we have today and HD cameras in the operating room, we're seeing things much clearer and much crisper. And I don't know of data that have compared the current technology to old technology, but I imagine if you polled most urologists, they'd say I'm seeing things so much better and crisper and cleaner both in the clinic and in the operating room. And I find that that's been a game changer for us. Let me just throw all of this up because this was the randomized trial that was conducted by with then Hexfix and now Cysview. I participated in 2 of the trials that led to the approval in the US. And you could argue, so this is statistically significant, you could argue that the magnitude of the difference, 16% long-term, isn't that great, but I think those of us who use it, I realize it's been available in Europe for a lot longer than it's been available in the US, is we just see more and see clearer. And then there was a nice paper published in a journal that I do have a conflict in. I'm the co-editor-in-chief of. This nice review suggested that there was a benefit in terms of progression. So enhanced cystoscopy can help us. It's approved for repeat use more recently, flexible cystoscopy in addition to monitoring, but it probably has utilities for all 3 of these, but they're not currently have regulatory approval. The study that looked at, in a similar design as the PDD registration trial looking at narrowband imaging, unfortunately was a negative trial in the overall patient population here, perhaps a benefit in low risk disease, but I think Fred's been championing for a very long time. Do we really need to it's okay to miss low-grade tumors. Mark Soloway has shown us that the untreated natural history is quite benign. And our focus, I think, in terms of our diagnosis really is to make absolutely sure that we don't miss a high-grade cancer. And biomarkers can certainly fit in there. So remember that cytology is a biomarker. It's a complex test. It's obviously something that we've used for a long time. Fred's given you the current EAU guidelines, the AUA, and I think the EAU as well. It's not indicated for patients with low-grade disease, biopsy-proven low-grade disease. And then I've already mentioned the importance of looking at extravesical sites in the patient with the unexplained positive cytology. When I say positive, I mean positive for high-grade urothelial cancer. Atypical suspicious, we don't view that as a positive test, but one that we do need to pay attention to. And so because of the limitations of cystoscopy, notwithstanding improvements in white light and enhanced cystoscopy, we still are going to miss CIS because it's often invisible and it's often quite small. Obviously, we don't have the opportunity right now to monitor the upper urinary tract except with a voided test, and you'll hear more about that. Cystoscopy, people, as Fred pointed out, patients don't like having a cystoscopy. And while we might think of it as our stethoscope, as a minimally invasive test, I've personally never had one, but I can assure you it causes a tremendous amount of distress and anxiety, and that's been well documented in the literature. And I don't need to show this group, but cytology is also an imperfect test, but it's one that, if done correctly, should have a very high performance characteristic for the detection of, say, biopsy-proven high-grade disease. So it really shouldn't miss a high-grade tumor that's of sufficient volume. And I would expect the performance characteristics to be in the range of 90% plus sensitivity. But what's interesting to me, I'd be curious to see what the other speakers feel, is that with the change in the grading system from the WHO 1973 to a binary low-grade, high-grade, some of those grade 2s, about 40% of those grade 2s are now considered high grade, and I wonder if that has sort of lowered the sensitivity for cytology. So this is just the party line in terms of the EAU with respect to cytology. I think I've summarized that so far. A negative cytology, though, does not absolutely rule out the presence of any tumor, but it should be working quite well for high-grade disease. So what's interesting is when you go into the literature, and I just happened to pick this study because it was a prospective comparison of, at that time, multiple biomarkers, obviously same patients compared to cytology. This is the patient population over here. The majority were low-grade. And cytology was performed with conventional, I think, state-of-the-art techniques. When you look across here on an individual basis, you'll see that the AUCs are quite identical. Combination biomarkers might give us a leg up, so perhaps a combination of cytology plus a biomarker, but I don't know that there's anything in here that's distinguishing any one biomarker compared to the other. If you look at this very nice review that was part of the ICD guidelines, and if you look over here, so this is sensitivity based upon stage, and let's just look at carcinoma in situ, where we really need to expect our biomarkers to perform at a very high level. You see that cytology is maybe a 2/3 sensitivity and really no better than the two biomarkers that are compared to here, BTA stat N and P22, both point of care tests. And then in just comparing low aggressive or low risk to high risk, let's just focus on this group and CIS. You'd like to get a bit more out of cytology, at least in this case. FISH and immunocyt, which is a combination of two surface carbohydrate-based antigens, and cytology seem to be performing quite well compared to cytology. And so if you look at the performance characteristics of EpiCheck that Fred has already shared with you, the high negative predictive value for high-grade disease is really about where you'd want any biomarker to be living and performing, assuming that gets tested and validated in larger patient populations. And so this is some of the data from Fred's paper that he's already presented to you. And I'll just highlight again where I think that we ought to be aiming for in terms of overall specificity, and particularly for the sensitivity and negative predictive value characteristics for really any biomarker in this space. And this area under the curve is really quite nice, and again in the range of where we'd expect it or want a biomarker to be in detecting patients who have high-risk disease, so either CIS or high-grade papillary disease. So I'd like to shift gears and talk a little bit about atypical cytology. Fortunately, the pathologists got together and in 2016, I think, provided this Paris classification. So, as I mentioned already, positive for high-grade urothelial cancer, every urologist knows that we have an absolute obligation to find out where the cancer is. So that always requires action. So 80% of the time, you're going to find it in the bladder. In the post-BCG treatment state, you got to look at extravesical sites. But I think that this suspicious for high-grade cancer is a challenge, right? Because we know that the way they've done this classification, it's simply based upon the number of cells above or below 10. So above 10 is positive for high grade, below 10 is atypical suspicious. The cells themselves, as you can see on this next slide, have a high nuclear to cytoplasmic ratio. They look like cancer cells, but it's just simply in the background, not enough of them are positive. So we know that this is going to be associated with a subsequent tumor event. Now, personally, I teach and I act. I don't act on this. All I do is continue to see the patient I'll see him again in 3 months. If I haven't gotten an upper tract study in the last year, I'll do that in the context of a history of high-grade urothelial cancer. So a biomarker can help us resolve this atypical suspicious cytology, and I already mentioned how I would respond to it. And then I'm also going to show you some data that would be quite helpful if we had a biomarker that could reliably predict recurrence and or progression after treatment with BCG. So you could argue that we'd also like to get it before treatment for BCG, and there's some interesting data about that. So there's 2 papers that have looked at, both from a prospective standpoint and a validation standpoint, using a biomarker as a reflex test for atypia. Okay, so what does that look like? So we're using fish. So how do I use a biomarker? In this case, I use fish. We use that at every point in time that we're surveilling a patient with a known biopsy-proven high-grade cancer. And so when I get this atypical cytology or perhaps a cystoscopy that's suspicious, this is the positive predictive value for this particular test. And in a patient who does not have a prior history of cancer, it also has a reasonably good positive predictive value. Essentially, it's communicating to me, if it's positive, that something is brewing, I need to stay on top of it. If it's negative, it gives me and the patient a lot of confidence that I really haven't missed anything. And then these are the performance characteristics in the validation study. This is work done by Yar Lotan, who has a tremendous amount of experience with fish. This is another study that I think showed something quite similar, and I'll just point out the mean time to recurrence. So this is atypical suspicious positive fish versus negative fish in terms of time to recurrence. So that's a short enough interval that we can keep our ears perked. Remember, this is cystoscopy negative in a high-risk patient population. And so this is really important for another reason, because this is a secondary analysis of a SWOG 8507, which was a randomization to induction BCG with or without 3 years of maintenance that established, along with an EORTC trial, the standard of care for 3 years of maintenance. But the status of the bladder at 3 months, so if you had a stratified by complete response at 3 months or no complete response, and this is overall survival, long-term, there was a highly statistically significant difference in outcomes. So we've got to get it right. That's my message, is we need the tools to make a very precise and accurate assessment of the response to BCG at that 3-month or 6-month time point in the case of CIS. So we have some tools to do that. This is data that was provided, a slide provided to me by George Tallman looking at IL-8. And then this is work from Ashish Kamat and another trial looking at fish done about 4 hours after the 6th installation of BCG, showing the predictive value of a positive fish at that time point. So we're beginning to see some potential utility of biomarkers. And then this is sort of a compilation. This is a slide that Badri Canetti put together showing the utility of fish in this very specific post-BCG statement area. So this would be another utility and a potential testable hypothesis with the use of EpiCheck. There are some data. Fred showed you a snippet of this, and if you just look here, what this is essentially showing you that with or without BCG and any of these factors here don't appear to be affecting the performance characteristics of EpiCheck. So at least that's another testable hypothesis in the post-BCG treatment state to look at it as a possible prognostic biomarker for recurrence in patients who've appeared to have a complete response. And then there's a very nice decision analysis based upon the same patient population that Fred's group reported on, again, looking at performance characteristics from a slightly different and unbiased view of EpiCheck and showing something quite similar in terms of the performance characteristics and the potential impact on clinical decision-making. And I know that Shirok Shariat was involved in this, and Shirok and I have a long history together of developing nomograms for muscle-invasive bladder cancer. And the benefit of a nomogram is in addition to getting the absolute value, you get the absolute value of the EPI score, as Fred pointed out, and it's a continuum here. So what you see here is that, so 60 is the cutoff, but if you have 50, that's a negative test, and that's going to contribute to the overall risk when you look at the other factors that are driving risk of recurrence and progression. So these types of nomograms really allow you to incorporate individual information, pieces of information, variables that we know are associated with subsequent recurrence and maybe progression, and incorporate, in this case, EpiCheck or into this, and then you come up with a score along this continuum for risk. We have, just to finish up here, some of the issues, again, with normal cystoscopy and a positive biomarker, how we might use that and how we might respond to it. Some of it's going to be dependent upon the patient population. And I want to emphasize what Fred pointed out is that in addition to the work that he's done, that our patients expect a very high performance and negative predictive value from a urine biomarker because of this fear of recurrence. And the fear of recurrence is well documented in many studies. And I honestly think that it's something that we underestimate because we have a sense of, low-grade disease, not going to hurt you, but the frequent recurrences, the frequent trips to the doctor's office, the frequent cystoscopy they're difficult for patients. So the question is then, if we have a biomarker that has a high negative predictive value, and you could potentially reduce the frequency of cystoscopy, particularly in high-grade disease, confidently, then we have to educate patients about that utility. So just in summary, I think our toolbox is, I need to get a bigger toolbox. Because we've got fantastic tools with imaging, and I've personally spent a fair amount of time looking at enhanced imaging. I think that's really been a game changer. And I think having a biomarker that is closer to point of care, although this one isn't quite there yet, something that's less complex, something that's less expensive to the healthcare system, but has the performance characteristics that our patients and we really need and expect, could potentially get into mainstream clinical practice. So thank you.
Okay, Seth, thank you very much. We have time for a short question. You really think we need a bigger toolbox in the coming few years? I hope so. Sorry.
Yeah.
Okay.
I have a great well, I have a great picture in the operating room where I have all of these different imaging things set up, and the enhanced imaging is expensive too, right? I mean, I just had a conversation about we have a particular vendor doing our cystoscopes, but to bring in a different enhanced imaging, it's another investment. Well, I want to have something that's a little less expensive than that if I can. So thank you.
Yeah, although we also all buy robots, they cost 2.7 million in my country. So there's a question, Seth. Maybe wait for us.
Okay, a boom from Germany. Thank you for this talk, Dr. Lerner. I quite agree with your conclusions. I want to make a point on the use of cytology. Cytology, the slide you showed, if you miss 20% of your high-grade lesions, then the conclusion here is that you obviously need more training. And that comes to the problem with cytology. It is a subjective method, such as all histopathology, and it needs, all cytologists need constant and good training and re-evaluations of their capabilities. And I think there is something that needs to be done. You should, in cytology, not miss more than 5% of your high-grade lesions. If you see high-grade lesions, you can have a tumor, obviously. You can also have sort of viral infection. And then I quite agree with you. This is the good idea to employ additional testing. There has been a long discussion on using the fish. Well, it hasn't really found its way into a clinical routine, probably because the test is rather cumbersome and expensive, and the EpiCheck probably has the potential to outperform the fish. Yeah, I'm quite convinced.
Yeah, the reason I used fish is because Dory Lamb, who's a scientist in our department for a long time, needed the instrument for her research work. So we said, great, we'll incorporate the test. So back to the cytology, are you a urologist or a pathologist?
I'm a urologist.
Urologist. So
and that's probably the point, that many urologists do it, and they do it, it's not their main occupation. I mean, cytology is not the main occupation of any urologist, or they give it away to the pathologist, and the pathologist has a problem with cytology, right, because it's much more difficult to interpret cytology without the clinical knowledge.
So, I mean,
Short answer, please.
Oh, machine learning for cytology. Take the pathologist out of it.
Okay. Thank you very much.